A 4-year-old child presents with status epilepticus and severe hypoxia. I am showing you an emergency plain CT scan of the brain. Describe the findings.
Okay, I see it. The non-contrast brain CT scan demonstrates diffuse cerebral edema with complete effacement of the cerebral sulci and cisterns. There is global hypoattenuation of the cerebral hemispheres, resulting in a complete loss of normal gray-white matter, corticomedullary differentiation. In striking contrast, the cerebellum, brainstem, and deep midline structures are relatively spared, showing a normal to increased density that makes them appear hyperdense compared to the edematous cerebrum. These appearances represent the classic acute reversal sign, indicating severe global hypoxic-ischemic brain injury.
What is the pathophysiology behind the reversal sign on brain CT, and what does it indicate clinically?
Okay. The reversal sign is caused by a severe, sudden hypoxic-ischemic insult that triggers an autoregulatory redistribution of cerebral blood flow, directing blood away from the vulnerable cerebral cortex to the essential hindbrain structures, specifically the cerebellum and brainstem. This causes severe cytotoxic edema and massive swelling in the cerebral hemispheres, lowering their density. The spared cerebellum and brainstem retain normal perfusion and density. Additionally, severe cerebral edema obstructs dural venous drainage, causing venous congestion that increases the physical density of the venous blood in the spared dural sinuses and cerebellum. Clinically, this sign indicates irreversible brain damage and carries a universally poor prognosis.
How does the distribution of hypoxic ischemic brain injury differ between premature infants, term infants, and older children?
In premature infants under 34 weeks of gestation, the paraventricular germinal matrix and deep white matter are highly vulnerable, leading to paraventricular leukomalacia, which spares the cortex, and deep gray nuclei. In term infants, the pattern depends on severity. A mild insult causes watershed infarcts between major vascular territories, whereas a severe insult damages the most metabolically active areas, which are the thalami, putamen, brainstem nuclei, and perirolandic motor gyri. In older children, a severe insult typically results in global cerebral cortical injury and diffuse edema, producing the reversal sign.
What are the early CT signs of hypoxic ischemic injury within the first 24 hours, and what is the preferred imaging modality?
Within the first 24 hours, CT can be normal or show only subtle findings, such as mild hypoattenuation of the basal ganglia, blurring of the insular cortex, known as the insular ribbon sign, and early effacement of the basal cisterns. Magnetic resonance imaging, specifically diffusion-weighted sequences, is the most sensitive and preferred modality for detecting early cytotoxic edema, showing restricted diffusion within hours of the insult. While head ultrasound is portable and useful for screening intraventricular hemorrhage or gross edema in infants with open fontanelles, its sensitivity for hypoxic ischemic injury is very limited.
How would you manage this patient as a radiologist?
In that case, as a radiologist, I would recommend comparing this CT scan with any prior neuroimaging or perinatal ultrasounds. I would suggest urgent clinical correlation with the patient's neurological status and recommend a brain MRI with diffusion-weighted sequences once the patient is hemodynamically stable to fully delineate the extent of brain injury. I would document the presence of the reversal sign and check for any complicating tonsillar herniation. Finally, I would immediately communicate these critical findings to the clinical intensive care team to guide systemic support and discussions regarding prognosis.